Local or general anesthesia, with or without a tourniquet, may be used. Administer IV regional anesthesia as per standard protocol. A bloodless field is achieved by tourniquet application. Place a towel roll under the wrist for gentle extension. A right-handed surgeon should be positioned on the ulnar side of the patient's right hand or on the radial side of the patient's left hand. Place a dot over the palm located 4 centimeters distal to the distal wrist crease. This indicates a point at or just beyond the distal edge of the transverse carpal ligament. Mark a 1 to 2 centimeter incision in the midline of the palm or just ulnar to the palmaris longus tendon and started 1 centimeter distal to the distal wrist crease. An incision located to the ulnar side of the midline decreases the risk of injury to the palmar cutaneous branch, the median nerve, and the recurrent motor branch. It also allows the ligament to provide an interface between the median nerve and the overlying skin. An incision too far medial from the midline may lead to ulnar nerve injury. Make a skin incision using a number 15 blade scalpel. Sharp dissection should be carried out through the subcutaneous tissue and palmar aponeurosis. Apply an iris retractor. Tissue retraction may also be supplemented by handheld Sen retractor. Incise the transverse carpal ligament. The transverse carpal ligament is identified by the classical appearance of the transverse direction of its fibers. Use a Woodson dissector to feel the undersurface of the transverse ligament both proximally and distally. Introduce the Dakota knife into the incision with the base plate positioned deeper to the transverse carpal ligament and directed toward the distal end of the ligament. Rotate the blade approximately 5 degrees toward the ulnar side. The non-dominant thumb should be placed just distal to the dot mark on the palm. Advance the Dakota knife slowly with a slight upward tilt of the leading edge toward the surface of the palm. Transection of the carpal ligament is heard, felt, and seen. After complete transection of the distal end of the ligament, the blunt base plate of the knife will push against the superficial tissue layers. The pressure applied to the palm by the non-dominant thumb prevents progression of the knife beyond the distal end of the ligament, thus preventing vascular, neural, or tendon injury. Direct the Dakota knife proximally again, with the blade tilted toward the skin. Divide the residual proximal carpal ligament. Advance the knife farther to transect the volar forearm fascia approximately 4 centimeters proximal to the distal wrist crease. Care should be taken to remain on the ulnar side of the midline. Withdraw the Dakota knife and irrigate the wound with saline containing vancomycin and gentamicin. Squirt 1 cc of decadrone under the carpal ligament. Remove the retractor and infiltrate the skin edges with 25% Marcaine. Close the wound with 3 mattress 5/0 nylon skin sutures. Apply a light dressing. To decrease post-operative bruising, apply pressure over the distal forearm and palm for approximately 7 minutes while the tourniquet is deflated. Apply a wrist splint. To decrease post-operative swelling, keep the hand elevated for 24 hours. Immediate mobilization of the fingers is encouraged. Remove the dressing and sutures in 12 days.